Welcome everyone to the last MycoClinics of this year. For those of you who have not joined the MycoClinics before, the MycoClinics is a webinar organized by the colleagues you are seeing in this slide and coordinated by the MSc Center for Medical Mycology, where clinical experts will present a case study with diagnostic considerations and process treatment deliberations, follow-up and outcomes. And at the end of the two presentations, we will have a panel discussion. During the webinar, you can submit your questions through the Q&A, and we will do our best to get through all the questions during the panel discussions. And we also will have recordings available after this webinar. So today's webinar, today's MycoClinics, is entitled Dermatomycosis, and we have two fantastic speakers for you this afternoon. Dr. Alireza Abdolrasouli, who will talk about Terbinafine-resistant Trichophyton indotineae, and Dr. Ananta Khurana, who will talk about clinical and therapeutic perspectives on Trichophyton indotineae. And I also want to introduce the chairs to you today. So my co-chair is Anu Kaudhari, from India, a medical mycologist, and myself, I'm Adelia Waris. I'm a pediatric infectious diseases consultant with a huge interest in medical mycology and one of the co-directors of the MSc Center for Medical Mycology. I just want to ask your attention for a number of other initiatives we are running through our center. The Medical Mycology Trainee Seminar Series, which is a specific webinar series for students, postdocs, clinical trainees, but also calling all new faculty, as you see in this slide. They are organizing talks on the second Thursday of the month. Another webinar we are coordinating is the MycoTalks, which is a monthly webinar. The information you will find all on our website as well. And here you see there is one scheduled for next week. Already the speakers for in January are also known, as you can see in this slide. And then the last slide I have for you is to just make you aware, if you really get interested in medical mycology by joining the webinars we are having for you, we also have a medical mycology MSc program, which can be done in either going for a certificate, the diploma, or the full MSc. Can be done full-time, part-time, a lot of flexibility. So also this, you can find information on our website. So without further ado, and I'm going to stop share my screen, I would like to introduce to you the first speaker, Dr. Ali Abdolrasouli. He is a principal clinical scientist of the UK National Mycology Reference Lab, and he has taken up this position very recently. And before that, he was the lead scientist of the mycology service at King's College Hospital in London. His main research interests include epidemiology of emerging fungal pathogens, laboratory diagnosis of fungal infections, and identification of pathogenic fungi and antifungal resistance. And he will talk about Terbinafine-resistant Trichophyton indotineae. And Ali, the floor is yours.
Very good afternoon, everyone, and thank you very much, Adelia, for a very kind introduction and for the invitation to be part of this prestigious and, in my opinion, very important series. I've always been listening to these talks, but this is the first time I am actually sitting on the other side. So thank you very much for invitation. And as soon as I heard trichomycosis or trichophyton infections, I said, oh, that's the best opportunity to talk about them, because it's a topic very close to my heart. What I am going to do within next 20 minutes is talking about a case that we actually saw in my previous role in London at King's College Hospital almost a year ago, and talked about some of the clinical aspects of this case. And by the end of the talk, you realize why I decided to present this particular case and not many others, because it has some unique features, at least for us as both clinical mycologists test and also laboratory diagnostic aspects of it in the UK, and I assume that would be relevant into many other countries that are still considered as non-endemic, although the epidemiology of Trichophyton indotineae infections is changing very fast. And number two would be taking you to the laboratory and showing you some of the lab aspects of this case that might be of interest to my colleagues that would like to identify this actually dermatophyte. So now the next slide, if I can move them. I start by telling you a little bit about our case. This is published, so I put the reference if anyone wants to look at the details that is available as well. This is a young gentleman in his mid-20s. He was born in the UK, and for the past 8 years, he also lived in the UK as well. He was doing an office-based job as a consultant in London with no significant past medical history. And when we saw him last year, he admitted that he had skin issues started in March 2023. He had a very, very lucky and extensive travel history, and that later on would be very useful when we talk to you about the epidemiology of Trichophyton indotineae. So at the early last year, he decided to have almost 6 months off from his work and do a very extensive travel to Central and South America. That was very, very lucky for him. So he visited several cities, including Mexico, Belize, Guatemala, Honduras, and Brazil, and he had some trips to the jungles, and for some of you that might be very exciting because some of his packs were carried by mules in Guatemala. He spent time in mixture of cities and rural areas because he had families and friends in both. He stayed in mixture of hostels and camping tents. So at some point he had exposure to soil and probably some dermatophytes that we know as geophilic dermatophytes. And my colleague would later on introduce them to you. And also he had contact with some locals, but he could not remember anyone with similar skin problems. He had contact with cats and dogs, but again, they look healthy to him. And he came back almost 6 months later to the UK via Portugal from Brazil. While he was traveling, and just to remind you of the fairly up-to-date picture, global epidemiology picture of Trichophyton indotineae, we don't have many reported cases from Central or South America. He had shared beddings and towels during his travel with friends and people that he spent time with. He was sleeping in sleeping bags during this period. He had experience of swimming in rivers and lakes, and for infectious disease doctors, that might be exciting. He was unable to recall if he had contact with anyone with similar skin rash, and he had no sexual contact within that 6 months. On clinical presentation, actually, he had claimed the rash started almost 3 months into his travel. So in March 2023, he started as a single patch on his right leg. I will show you some pictures later. It was itchy, and at the beginning, he himself and his friends thought it was eczema. Then this rash started to spreading to his thighs, legs, face, eye, groin, and buttock. There was no rash over the trunk, and it was bleeding on scratching, and there was no discharge or pus. And whenever he was in humid and hot environment or after sports, these would become worse. There was no further symptoms or fevers. This is a summary of the timeline of events, and in order to save some time, I'm not going to tell you about every single antifungal treatment he received within this period, but you can see from early January to almost late July, he was spending his holiday in Central and South America. Skin lesions started in almost first or second week of March. After that, he had multiple courses of topical antifungals, each for 2 weeks. He could not remember the exact name. These were over counter. Then After returning to the UK at the end of July 2023, he had a visit to his private practitioner. It was assumed this was a type of skin dermatophyte infection. He received 2 further courses of topical antifungals, including betamethasone and clotrimazole 1% cream, each for 2 weeks. This was followed by terbinafine 1% cream, again for 2 weeks. And in each time, there was partial response, but not full resolution. Rashes at multiple sites skin stay as they were, and we finally saw him at King's after a failure to respond to all of these treatments. Now we look at some of these pictures, and this is quite interesting because when we talk about Trichophyton indotineae, most people believe these are the lesions start in groin area, but in this case it was started on the leg and not on groin. And then you will see multiple lesions on multiple sites, including both left and right groin, fairly large, which is in line with what we expect to see with Trichophyton indotineae. They were scaly. There were a single large lesion on the left buttock, and also on the back of the neck, and on the right subclavicular bone. And at this stage, we decided, okay, this is very much in line with a trichophyton infection or a dermatophyte infection. And what we do is to collect multiple skin scraping lesions, and we did that. One of the things that I would like to highlight is the probable role of collecting multiple samples. And we actually sampled almost every single of those lesions because we were very excited to see what we are going to isolate from him, because we had no idea on that time this would be a Trichophyton indotineae infection. And there are, after that, several cases that I was involved, and we noticed that collection of multiple samples from multiple sites, if there are more than one site involved, would facilitate isolation of dermatophytes if particularly one site is negative. And this is a very busy slide, but to highlight what we do in the diagnostic laboratory for isolation and identification of dermatophytes in general and Trichophyton indotineae in particular. And you will see we have separate workflows when we collect the samples. We can do direct microscopy. We usually use chalcofluor white stain to visualize them by fluorescent microscopy. We culture them on different media. I'm not going to the details. And when we grow a dermatophyte, we again repeat the microscopy to look at its phenotypic characteristics. And there are laboratories that try Malditoff. We tried that, and we got an identification of Trichophyton mentagrophytes complex in this case with a very good score. And I talk about the role of urease hydrolysis later. But with putting all of these findings together, we highly believed this could be a potential case of Trichophyton indotineae, but the travel history didn't match what we expected, and obviously we had to confirm that. Therefore, the isolate gone to the reference laboratory for further investigation, including sequencing and antifungal susceptibility testing. Show you some of the microbiology or mycology laboratory results. This is direct microscopy from skin scrapings. Almost exclusively, all of the samples we collected from him were positive from multiple sites, and you can see narrow septate hyphae were clearly observed in all of these samples. This is the culture of some of these samples collected from him after 2 weeks incubation, and at this stage was very difficult to provide any phenotypic identification, but after extended incubation we had colonies that very much was convincing for a Trichophyton indotineae. But as most of you know, both macroscopic features of Trichophyton indotineae is very similar, to some extent indistinguishable from closely related species of Trichophyton interdigitale and mentagrophytes, and therefore we can argue that we need more evidence to identify that. I will not discuss this in details at this stage, but we can revisit them later on during the discussion if there are questions around them. And particularly I want to ask you to look at the top panel with macroconidia that quite, I believe, in our hands, unique when it comes to Trichophyton indotineae. We usually do not see these macroconidia in Trichophyton interdigitale, which is probably the most common dermatophyte get mistaken in the diagnostic laboratories, with chlamydospores here on the lower panel and some chains and a spiral hyphae, which again you would be able to see in interdigitale and Trichophyton mentagrophytes. One of the tests that usually labs can easily do, and most microbiology labs and mycology labs do have it available, is a urease hydrolysis. Even bacteriology labs have it, and we tested that, and in this case it was weak positive. But this is a bit of a subjective testing. And to highlight one of the issues about dermatophyte identification, which is not unique to Trichophyton indotineae, is phenotypic variation among one species and different strains. And this is a very well-known established characteristics of many dermatophytes, including the common ones like Trichophyton rubrum and interdigitale. And here I try to show you 4 different strains of molecularly confirmed Trichophyton indotineae with significant morphological variation on same agar, same incubation time, and same incubation conditions. But we now thankfully know that there are 3 single nucleotide polymorphisms or mutations in ITS region of Trichophyton indotineae can be used to differentiate that with closely related species. They are highlighted in this slide. And we were lucky enough to do a CLSI broth microdilution susceptibility testing. This is not the isolate from this case, but it's a very similar case, and we can obtain an actual minimum inhibitory concentration figure or value for terbinafine. And although it's open to debate, if we believe MIC of greater than 0.5 milligram per liter can be used to separate wild type and non-wild type. In this case, we had actually terbinafine-resistant or high MIC value to terbinafine in the isolate from our patient. We treat him with actually itraconazole for 2 months, with obviously monitoring his liver function and all of those things with a complete resolution, which I'm not going to show you pictures, but they are available in the published case. Very slowly, I'm going to close my case, but this is a recent survey in the United Kingdom and some laboratories outside the UK, when a Trichophyton indotineae and closely related species Trichophyton interdigitale have been simultaneously distributed to the mycology or microbiology laboratories for identification. And you will appreciate a sharp contrast between the capabilities of mycology or microbiology labs to correctly identify these 2 species, and this highlights the need for further education and work in this area. In Trichophyton interdigitale, which probably is one of the most common species microbiology labs are familiar with and identify, in this case, 86% of the labs in the UK and 75% of the labs that got the distributions, including outside UK, correctly identify this. But if you look at the top panel, when Trichophyton indotineae was distributed, only 42% of the UK lab and 49% of entire participating laboratories were able to identify this. And to summarize, we put this with Professor Rod Hay into British Journal of Dermatology a few months ago to propose a potential workflow for both primary care providers and also dermatology or even infectious disease specialist centers that see cases that potentially could be due to Trichophyton interdigitale or indotineae, and they cannot differentiate them. And we propose that maybe referral to specialist services would be beneficial. And also we suggested, until we have a robust identification system available for the laboratories, they probably need further investigation in the reference laboratory, and that includes molecular and antifungal susceptibility testing, and also having a national surveillance program, because we also observed a recent sudden increase in the UK number of cases of Trichophyton indotineae that are referred to the National Laboratory here in Bristol that I am currently based for identification. The reason now I'm going to close my case that this case to me as one of the earlier published cases from the UK was important was because there was no obvious ethnic travel link at all to endemic area. So we were basically just looking for a dermatophyte that we had no evidence could be Trichophyton indotineae. So this is very important for people outside endemic area, that you should not always assume there should be a direct link to endemic area, either ethnicity or by travel. Partial response to topical antifungals or steroid creams is a very common feature in Trichophyton indotineae cases, and that was also the case in our patient. Recurrence and widespread lesions, again, as I showed you some pictures in this case, and I tried so far to convince you that the accurate laboratory identification of indotineae still remains challenging, even in the labs with quite capable mycology expertise in-house. Whether we require antifungal susceptibility testing on all isolates is debatable. Some isolates still show low MIC to terbinafine, but I believe response to terbinafine as first-line treatment is open to debate. We can take this one to our question and answer session and discuss it with the panel. And also, we believe some of these patients do need follow-up, and it's in a way different from other dermatophytes that we prescribe an antifungal and we discharge these patients. And I guess having a further follow-up would be beneficial, particularly if we leave them for shorter duration of antifungals, to be sure there is no recurrence, no transmission, and they respond very well. So on that note, I would like to close this talk by thanking my colleagues and collaborators here in Bristol, St. John's Institute of Dermatology. So in Bristol, Professor Elizabeth Johnson and Professor Andrew Borman. St. John's Institute of Dermatology, I had the support of Professor Rod Hay, and at King's College Hospital, Dr. Maurizio Arias actually led the clinical investigation. Thank you very much for listening, and I'm happy to answer your questions during the second part of this session.
Thank you so much, Ali, for a wonderful talk and a very interesting case presentation. I see people are already putting questions in the Q&A. Please keep doing that, and we will get back to those later on. And I'm going to hand over to my co-chair, Anu.
Thank you, Delia. And thank you, Ali, for such an exciting talk and giving it such a wonderful experience of yours, sharing your experience from the UK perspective. And I'm delighted to have our next speaker, who is going to share her experience, enormous amount of experience dealing with Trichophyton indotineae from India. So we have another speaker, Dr. Ananta Khurana. She is going to talk about clinical and therapeutic perspectives on Trichophyton indotineae. Dr. Khurana is a professor in the Department of Dermatology, Venerology, and Leprosy at one of the prestigious institutes in Delhi, Dr. Ram Manohar Lohia Hospital. Her main area of research includes dermatophytic infections, but she also works on leprosy and other hair disorders. She has contributed more than 100 scientific publications and authored several books. She is presently section editor in the Indian Journal of Dermatology, Venerology, and Leprosy, and also associate editor of Indian Journal of Postgraduate Dermatology. Over to you, Dr. Khurana.
Thank you so much for the introduction and also for the invitation and the wonderful collaborative work we have done on Trichophyton indotineae so far. So taking forward from where Dr. Alireza has mentioned, so I shall be talking on the clinical and therapeutic perspectives on indotineae. So largely our experience in India in dealing with this organism over the past few years. So definitely since the advent of Trichophyton indotineae, there has been a tremendous change in how tinea presents and how we treat it and follow up. You know, it has completely changed. So, and this is of interest and importance to both clinicians as well as microbiologists. So while Trichophyton rubrum and mentagrophytes to some extent was what we were dealing with before, and currently it is almost a complete predominance of this new species, Trichophyton indotineae. Now, the earliest reports and the earliest shift happening was noticed probably early 2016-17, and these are some of the earliest reports from the country regarding this, regarding that there was a change in the organism causing tinea of the glabrous skin and its susceptibility profile, especially towards terbinafine, which had been a drug of choice for tinea corporis cruris so far. So this brought to attention how the epidemiology of tinea had started to change. And it was soon found out that this changing dynamics was attributed to a new species which had been coming up. And much later, it was given the name Trichophyton indotineae, as we know now. The earlier reports mentioned probably the similar organism as mentagrophytes or interdigitale. And so since the earliest reports from the country, there has been a spread of Trichophyton indotineae probably related to international travel, migration. So, every few weeks there is a new report coming from some part of the world. So now it's been isolated beyond India from many countries in Europe that, like Dr. Alireza had mentioned already, from North and South America, there are isolated reports, and also from as far as Australia so far. So this is the latest data, just to give you an idea about how much the bulk of Trichophyton indotineae we encounter in India right now. So these were isolates, the skin scrapings of patients from our hospital, and these have been processed by Dr. Ananta Chaudhary at her lab. So if you see, there is almost a 70% rate of isolation of Trichophyton indotineae from skin scraping. So that's like a major chunk of tinea corporis cruris we see is attributable to Trichophyton indotineae. So fortunately, the same shift has, it seems, not yet happened in onychomycosis, the dermatophytic onychomycosis. And Trichophyton rubrum, which is isolated still from nails, remains susceptible to most first-line agents. Now, this is one report from various centers across India where they collected samples from North, East, West, and South zone. And it is interesting to see that there has been this species shift noticed all across. Slightly less in the East, but North, West, South, you can see upwards of 80% of isolation of this changed species now. And now my major chunk of my talk will be how this affects clinicians. So how we treat and encounter tinea, how it affects that. So largely the challenges as a clinician we face are, apart from clinical and diagnostic and treatment, are also the relapses which have become much commoner with the advent of Trichophyton indotineae. So here we have summarized how the clinical presentation of Trichophyton indotineae skin infections is different from what used to be with rubrum and the older species we used to encounter before. So the typical morphology of a ring-shaped lesion, central clearing, is often not found, and we often get very extensive infections. So these are some examples. Now, peculiarly, face has become a very common site of involvement, and a site which leads to a lot of diagnostic confusions because firstly, it is amenable to a lot of topical steroid applications which patients can find over the counter. And secondly, intrinsically also the morphology of tinea with Trichophyton indotineae is very variable on the face. Sometimes there is only a bit of scaling, barely any erythema. Sometimes we do see the typical lesions also, but mostly it is these atypical lesions we see on the face. They may be extension onto the outer ear, sometimes extension into the scalp. And sometimes you would see only this very subtle erythematous papules and minimal or no scaling at all. So these cases do give a lot of diagnostics challenge to clinicians. And then there are cases which look more like eczema, like Dr. Alireza had presented in his talk. This patient was also probably considered to have eczema first. And then there is a peculiar involvement of the scalp without actually causing a tinea capitis. We often see the skin lesions from the external ear, from the nape of the neck extending into the scalp without the changes of the hair infection per se or trichoscopy or otherwise. And then now we see a lot of tinea in very young age groups, which was very unusual before. So infants as old as months or sometimes even weeks presenting with tinea cruris, tinea fasciae. It has become commonplace. And then there are infections which are extremely extensive. So it can present with or without any underlying comorbid conditions. Like this patient on the right did have some underlying comorbidities. He was on cytotoxic drugs for a blood malignancy, but the patient on the left, who also has about 60-70% of skin surface involved, she had absolutely no comorbid conditions to explain this extent. And this was actually the first case of erythroderma due to tinea, which we encountered way back in 2017. So erythroderma, we use the term when there is involvement of more than 90% skin surface with scaling and erythema. So, tinea was not usually a condition we would consider in the differential of erythroderma before, but now we do. Another extensive patient now, and this patient on the right has been a particularly difficult patient to treat because she had been mistreated with a lot of oral steroids by practitioners in her village, and now she has to be on replacement steroids because of a severe adrenal suppression she developed with those. And tinea will never go till the point you give effective antifungal. So any amount of steroids is going to suppress the inflammation, but it always remains somewhere. And sometimes you also encounter such patients who have taken or abused so much of oral or even parenteral steroids that, the tinea has, it alters in morphology. It's difficult to really diagnose and identify the lesions correctly, but they come with such side effects of steroid abuse. And commonly, buttocks is a very common site of involvement and a site which actually requires prolonged treatment. So even though seemingly restricted area, sometimes we have to prolong treatment a lot because this site particularly becomes quite treatment recalcitrant. So apart from that, there is often a prominent pigmentation which is left behind after effective treatment has been done, and this can be very bothersome for some patients. And then lastly, some patients have very persistent pruritus. Even after achieving clinical and mycological cure, they continue to have a lot of itching, and it's then difficult to explain to them that the infection has actually gone, but some amount of pruritus may actually persist for some time. So why these differences in presentation of tinea? I mean, we really don't know as yet. So probably it's something to do with the virulence of Trichophyton indotineae or how it interacts with the human host or subverts immune response. So we did know with Trichophyton rubrum and the older anthropophilic species that they had the capacity to subvert immune response, both at the innate and the adaptive immune response levels to some extent. But how Trichophyton indotineae is doing it, it is not yet clear. There have been some studies from the country where they have tried to see any difference in the immune response between chronic disseminated versus localized and relapsing tinea. So one common thing which has been found here is a heightened IgE response, so something of a atopic sort of immune response. But the others findings have been very contradictory between studies, the role of Th1, Th2 cell lines. And then there was this another study which found a heightened Th17 response and inability of the Treg, the T regulatory cell line, to actually counter that inflammation. So there is more which needs to be done to understand this aspect. So diagnostics has been covered extensively and in quite details by Dr. Alireza. I will just focus on some clinical points which we use in our regular clinical settings in OPD. So we do not need diagnostics in for making a diagnosis and starting treatment for most patients, except some such patients where there is a diagnostic confusion in how the lesions present, or you can see in these patients there is some amount of lichenification or thickening of the skin. There has been recurrent tinea, but we don't know whether tinea is still active here. So some such cases do require lab diagnosis also. So apart for all the investigations which are available and in an expert mycology setting, in a clinical setting, in an OPD setting, what we go for mostly is a direct smear examination. So it is a fast and would give you a result within half an hour on an hour. So we do that especially for difficult to diagnose patients and the chronically relapsing patients. We use regularly a higher concentration of KOH than recommended for skin scrapings to hasten the clearing so as to get the report faster, start treatment faster. So this is how a KOH smear of an untreated patient would look like. And we have observed over time that when you start an effective antifungal treatment, there is some significance of also repeating KOH to know how it is responding. So with an effective antifungal treatment, you would see a reduction in the bulk of hyphae you see in a field There appear breaks within the hyphae, the fragments of hyphae, reduced branching. So probably these changes predate the onset of clinical response and may be helpful to know whether the antifungal you have initiated is actually being beneficial. So it is actually interesting that some studies have also found that a follow-up on KOH is not very far behind the follow-up you can do using a qPCR in terms of the positivity down the treatment. So next, coming to the treatment challenges for Trichophyton indotineae, and this is always a big question for clinicians as to what drug to use, what dose, and the duration. So I shall be taking the few most commonly used drugs against dermatophytes here. Firstly, starting with itraconazole, which is perhaps the drug of choice in the current scenario. So what happened with the advent of Trichophyton indotineae was that an empiric usage of higher doses and longer durations started, and the pharmaceutical industry has been, very active in these years. Earlier, we used to have only a few brands of 100 mg pellet-based itraconazole formulation available in the country, and now there are higher dose formulations. There's pellet-based formulations of 200 and 400 mg. And there is super bioavailable itraconazole, which is available in various strengths, 50, 65, 100, 130 now. And this all has stemmed from the perception of clinicians that Trichophyton indotineae requires more than the usual dose, requires more than the usual durations of treatment, and there is some amount of itraconazole resistance also, which is actually unfounded because all recent studies from the country actually report itraconazole to be highly effective against Trichophyton indotineae still. So there have been a lot of studies where disappointingly low cure rates have been reported with itraconazole also. But if you look closely, these studies have all used short fixed durations of treatment, 4 weeks, 6 weeks or so. And then the low cure rates are actually expected, but then we cannot really make conclusions like this. This is not justified to say that all antifungals have lost efficacy. So this is something which creates an alarm and leads to very irrational prescriptions by clinicians. So what this only signifies is that the short fixed durations of itraconazole do not work anymore like they used to work. So to identify and to establish what is the optimum dose and duration of treatment with itraconazole in tinea corporis cruris, we did this double-blind RCT some time back. And here, because the purpose was to see how much treatment duration is required to treat with itraconazole, so we gave the drug a good margin, defining treatment failure only when there was an absence of significant clinical improvement, even after 8 weeks of continuous treatment. So we divided the patients into 3 groups. The investigators, the clinicians assessing the patients were also blinded as to which group the patient belonged to on follow-up. So patients were given 100, 200, or 400 mg of itraconazole per day, and then they were followed up till clinical failure or cure. So this is what we found, a high overall cure rate achieved with itraconazole, 92%. And then a surprising finding was that 100 and 200 mg of itraconazole both had very similar cure rates, not statistically significantly different from each other. And this somewhat contradicted the norm, which has been to use a higher dose, a 200 mg dose of itraconazole as a starting dose in every patient. So this is not really needed. And this cure rate actually upwards of 80% in the setting of a clinical trial is on the same lines as the cure rates we have seen with itraconazole at the point this drug was introduced in the 80s or early 90s. So, trying to explain these findings of a similar cure rate between 100 and 200 mg, with a higher dose. Also, I would like to present this study. This actually predated the RCT. So here, what we were trying to see is, in a similar pattern to the RCT, we gave patients 100, 200, and 400 mg of itraconazole to different patients. And here we measured the serum levels achieved with each of these doses in all of these 21 patients. So what we found here was the serum levels with 100 and 200 mg were also not significantly different. So what 100 and 200 were achieving were largely similar in order of magnitude. The 400 mg achieved a higher serum levels. So what the point to be highlighted here is these 10 patients out of this whole group of 21 who had very low serum levels of less than 0.2 microgram per ml, and yet out of these 10, only 2 actually failed treatment. The other 8, even with this low serum level, actually achieved cure with itraconazole 100 and 200 mg doses. So it is important to understand here that with both itraconazole and terbinafine, the concentrations which are achieved in the stratum corneum, that's the layer of the skin where the tinea infection actually is there. So the dermatophytes are present. So the concentration achieved in the superficial most layer of the skin is much higher than the concentration of these drugs in serum. So probably that explains why even with a very low serum level, we were able to achieve cure with itraconazole. And that also explains why there is no significant difference in the clinical cure between 100 and 200 mg, because they also achieve similar levels in serum, and we can say that it's a surrogate marker of the levels this dose achieves in the stratum corneum, so that's also likely to be similar. Next, which was a very important point for this study, was to see the duration of treatment. So here also, if you see the range of treatment, it varies anywhere from 2 weeks to 20 weeks. So there are very few patients actually who would respond within a short duration of a week or 2 weeks or 3 weeks, and the mean treatment durations are roughly between 6 to 7 weeks. So here also 100 and 200 mg fared similarly with similar duration of treatment required to achieve a cure. 400 mg was slightly less at 5.2 weeks. And then we tried to compare how our results, compared with the fixed duration studies which had been done before. So we saw how many of our patients achieved cure at 4 weeks, 6 weeks, and 8 weeks, and it was largely similar to what others had reported. So the point to understand here is if the drug is given for a short interval of time, the cure rates will be less. So we have to give longer durations of treatment. There is no escaping that. Trichophyton indotineae, even to a drug to which it is sensitive, that is itraconazole, it requires a long treatment duration to achieve cure. We also compared how fast the response occurs with various doses of itraconazole, and surprisingly here also 100 to 200 mg fared similarly. In the time to achieve 90% clinical clearance, there was a significant difference between the 3 dose groups, however. Then this is an important consideration, considering the sheer bulk of infection of Tinea corporis cruris, which is, there in the community. We must understand that when we are trying to achieve a cure with a higher dose, we are adding much more cost of treatment. So to achieve a cure with 200 mg, it requires about 1.6 times the cost as to achieve a cure with 100 mg. And with increasing the dose to 400 mg, to achieve the same endpoint of cure, you're making the patient shell out about 2.2 times more amount than achieving a cure with 100. So whether the patient is shelling out himself or herself, or the state, or its government supplied, I mean, it's a lot of expenditure on healthcare here. So coming next to terbinafine. So once a drug of choice, this is probably the second line drug, but I though still use terbinafine as a first line also in many patients. So it was clear that with this changing dynamics in tinea, there had been a shift in how the prevalent organism responds to terbinafine in vitro. So there are increased MICs, and there's documentation of squalene epoxidase mutations and many isolates. But and then there is this very interesting study, again, I think I have referred to it before also. The isolates from different parts of the country show that though North, West, and East have a similar degree of terbinafine resistance, it is much less in the South. And this, likely it translates into clinical situations also, because, we have colleagues from the South who say that terbinafine works much better in their patients than probably it does in the North and other areas. So here too, of late, since the advent of indotineae, there have been studies to actually ascertain what the efficacy of terbinafine is in the current scenario. So again, many fixed duration studies which have reported quite low cure rates with it. So in this paper, this was a collaborative work again with Dr. Anuradha. So we tried to see how the patients who had isolates, which were later found out in lab to have high MICs and to harbor SQLE mutations, how they responded to terbinafine actually in clinical settings. So there was this group of patients, we started them on a starting dose of terbinafine 250 mg once daily, and we assessed them every week. So if they had not achieved any significant response, by 3 weeks, we shifted them to a higher dose of terbinafine, 250 mg twice daily. So that was not a regular used dose of terbinafine in those times. What we wanted to see what the response would be to increased dose. So, and then in some patients who also did not respond to that higher dose, we shifted them to itraconazole. So here, as you can see, many of the patients who had high MICs in vitro, who had squalene epoxidase mutation in their isolates, also did respond to terbinafine when the drug exposure was increased in terms of increased duration or increased dose. So roughly a cure rate of 70% was achieved still by increasing the duration and dose for terbinafine treatment. So terbinafine still I'm sorry, remains a useful drug for dermatophytic skin infections. So although the cure rates with the standard dose are not as they used to be, but a higher dose of 250 mg BD is able to offset the effect of high MICs to a large extent. And this is something we know for other antimicrobials also, that to some extent the resistance can be overcome by increasing drug exposure. Coming to greasophulvin, well, this is not a first-line agent for tinea corporis sclerosis. It has not been for many decades, but some clinicians do vouch for it still. So a lot of greasophulvin failures were already seen in the 80s and 90s when terbinafine and itraconazole came in and they became the drugs of choice. And in fact, there has been a study in probably in 80s where they found that any MIC above 3 microgram per ml, it prevents a clinical response to greasophulvin. And what we see with Trichophyton indotineae in the current scenario, the greasophulvin MICs are definitely much higher than that. Now, ketoconazole has had a moderate efficacy between 60-70% historically. So although this drug is not available in many countries, it's been banned at many places because of its hepatotoxic potential. But it may be a useful drug in some cases who have not responded to other drugs. So a similar efficacy as seen historically was also noted in this recent study using ketoconazole 400 mg per day. Voriconazole, not really a drug you would use for dermatophytic skin infections much, but there again have been studies using voriconazole also, like a last attempt to find another drug which is effective for Trichophyton indotineae. But what is important to note here is that the cure rates with voriconazole are also not significantly different from what we achieve with itraconazole. So it's not really the time to shift on to this third generation azole. So, and plus this is also a difficult drug to use, a narrow therapeutic range. It's very expensive at most places, and using it more rampantly for innocuous skin infection would predispose other invasive organisms to becoming resistant. So not advisable to be used for dermatophytic skin infections. Now, antifungal combination, so in an attempt to increase cure rates, have a faster cure response to treatment, this is also something which comes up in discussions in dermatology conferences. So to decide whether a combination of antifungals will be better than one antifungal alone, first we need some in vitro data. So like this study did find that there was an in vitro synergistic effect with combination of itra with luliconazole with terbinafine. However, the clinical evidence related to the use of combinations is not supportive. So there was this study where they used itraconazole in different doses and a combination of itraconazole and terbinafine, and the authors noted that the combination of both drugs was not superior in efficacy compared to itraconazole alone. So this is something similar is probably what we see in invasive mycosis. So even when there is a in vitro synergy, it rarely stands the test of clinical trials, barring few organisms. So now this, I would like to highlight, this is probably the first study in tinea skin infections, which actually evaluated whether adding topical antifungals to an already effective systemic antifungal actually has some benefit to giving systemic alone. And this is especially important in the current scenario because we see infections which are so extensive. So is there really a point in adding, the cost burden and then another point in prescription of adding a topical antifungal when we are already giving a systemic effective antifungal to the patient? So here the authors reported a similar cure rates and relapse rate for both group of patients who were given luliconazole in addition to itraconazole versus who were just given a bland emollient in addition to itraconazole. So some food for thought whether we should be prescribing topical antifungals to all patients who are on systemic antifungals also. So antifungal combinations, not much evidence to their favor, and we are not there yet. We do have effective antifungals which work effectively alone also. So not the time to use antifungal combinations at all. So the last of the challenges and most significant probably and disturbing challenges as a clinician and also for patients is the relapses. So you treat a patient with the best drug duration, you ensure a clinical cure and a mycological cure, but then the patient comes back to you after a few weeks or months and they're back with a relapse. So we have gotten used to the fact that, we live with the fact that tinea does require long durations of treatment now, but relapses is something which is, more disappointing. And interestingly, the relapse rates have been very similar across drugs. So with terbinafine, even with itraconazole, ketoconazole, a similar degree of relapse is seen. So it is unlikely to be something related to the drug we are using or the duration we are using it for. So in our study, we found that about 47.4% patients actually relapsed even after ensuring the best compliance, follow-up, mycological cure at the end of treatment. And interestingly, there was no difference in relapse rate between the three drug groups 100, 200, and 400 mg. Also, there was no association of relapses with how extensive the infection had been, with how long we had given the patient itraconazole for achieving cure the first time, and whether they had used other antifungals in the past. So what really drives these relapses is really not known now. So probably it's some virulence factor again, some ability of this organism to remain dormant and then come up again when the antifungal pressure is gone. But one good thing here is the relapses are also amenable to the treatment in the same way as the original infection is. So relapse per se is not an indication to change antifungals from the antifungal used initially. So carry home points, Trichophyton indotineae presents with a lot of modified clinical presentation, extensive skin involvement, atypical morphology. Itraconazole and terbinafine remain first-line drugs, but terbinafine in a higher dose, 250 mg twice daily. Long treatment is essential, and treatment till cure is the dictum. There is no role of fixed duration treatments anymore. And KOH can guide follow-ups, but you should remember and tell the patient, counsel them also at the time of initiation of treatment and at the time of stopping treatment also, that relapses can happen and will happen in a lot of patients still. So what we need further research, we want the mycologists to do this research and other clinicians also to study factors why there is a slow response to itraconazole in spite of a high in vitro susceptibility. Are there some other factors involved there, some other resistance mechanisms involved there? And especially what is very important for clinicians and patients alike is why these infections are relapsing the way they relapse. So this is something which requires more research, and a lot of what I discussed today, we have summarized in this review article we published 2024 April. So you could go through that as well. Thank you.
Fantastic. Thank you, Ananta. Thank you for such an excellent talk and actually discussing all the therapeutic options which are so far tested and available for Trichophyton indotineae infections. And with this, the session is now open. We're going to discuss the questions which we have got in the chat. And thank you, Ali and Ananta. Now the questions, I'll be taking some questions which will be either first for Ali or some of the questions will be both of you, if you want, both of you would like to answer that. So my first question is for Ali, that very interesting question. I mean, from the clinical side, does the exact species name, indotineae, MIC, really matter? Or is this response or lack of response to treatment that is more important factor to decide, I mean, how to manage? So what will you say coming from the lab, Ali?
You shouldn't ask this question from me, because I would definitely say it does matter, and these organisms behave differently. Having said that, we just like 2 weeks ago had a fairly extensive Tinea cruris corporis caused by Trichophyton rubrum in a young man with no travel history and resistant to terbinafine. So we can argue that from clinical perspective and patient management, probably we don't need the exact species name, but from epidemiological point of view and from public health point of view and from national surveillance point of view, we do need who is causing the disease, and otherwise we are going to lose the track of monitoring and all of that. So, and I am based in a laboratory, I would like to know what is the pathogen. If there is a capacity, I would say yes, but probably the first line of patient management doesn't necessarily need a name and an MIC value.
Yeah, I completely agree. For surveillance purpose, for maintaining, it's so important to have the name of the fungus and to monitor the trend. Thank you, Ali. So, Dr. Nanta, we have
Can I
another question.
come in, Anu, here? Because I was just wondering, and maybe for both speakers, I mean, you could treat clinically. You start with terbinafine, I assume, because that's our first line. But would you do any, is it a disadvantage to treat an indotineae for 4 weeks before you decide, okay, this is not going to work. I might deal with something what is not terbinafine sensitive. I mean, then you're 4 weeks in and you have a kind of progressive dermatomycosis. Is that what we want to do? I mean, I find it a difficult one as well, but I would just hear your thoughts about it.
Do you mind we just both answer to these questions, because I think we are
Yes.
coming from a very different setting, and I think Dr. Ananta's perspective is very valuable from a perspective that you see lots of cases. And I think in the UK we are now going through that shift. And I do not want to exaggerate on one of the examples I'm going to provide to answer to your question. Almost 6 months ago, I've seen a young patient in the UK with 4.5 years of treatment failure, and none of the private and basically NHS service that he has been consulted thought about this might not be what they thought they are treating. So at least in the settings that there is less awareness, we can't just say, go and have terbinafine for 6 weeks, you will be fine. And that was exactly he has been told for 4 years. And it was Trichophyton indotineae. So hands up to Ananta.
Yeah, so I agree. Even the first question asked, so there is a need for a surveillance to, we need to know our enemy, what we are dealing with. So in a setting where we are predominantly dealing with Trichophyton indotineae, the first line treatment also would be different to where you are predominantly still dealing with rubrum or other organisms. So when we're dealing with indotineae, we know that, we need to give the drug longer. Probably itraconazole can be the first choice already, or terbinafine in a higher dose. So without waiting for the standard dose regime to fail and then shift treatment, we have to be proactive from the beginning in a setting where indotineae is predominant.
Okay.
So we're shifting to the next question, where I think this was not covered entirely in both the talks. So can you, Ali, give an overview of molecular etiology of the terbinafine resistance? Is there a mutation in SQLE gene? Is it possible to perform genome sequencing of the patient isolate in different settings?
I have two different answers which gonna contradict each other, but I think that also reflects on the reality of life. Yes, my heart tells me that we should do sequencing and know the mutation, but the other side of this, which is the reality side, is I also had some sort of experience that there was no mutation, low MIC to terbinafine, but treatment failure. And then this opens a very difficult conversation whether terbinafine failure always correspond with in vitro raised MIC or the presence of mutations, or perhaps presence of other unknown mechanisms outside sequelin peroxidase gene, which so far we identified as the drug target and those mutations. unless we sequence more isolates, we wouldn't be able to address that. But I guess you are the pioneer of azole-resistant in Aspergillus. It's the same scenario. If we do not sequence, we don't know there are non-CYP51A/B mutations causing azole-resistant in Aspergillus. So yes and no. We need to sequence, we need to look for cause of resistance, but at the same time, treatment failure clinically may not always be as a result of finding known mutations in an isolate in front of us.
Can I ask the same question from, perspective from Dr. Ananta, because she also has a experience dealing with SQLE mutations, patients with known SQLE mutations and treatment. So Ananta, would you like to highlight some aspects from your experience?
Right. So there are many factors for treatment failure. One of them is in vitro resistance, but there are other factors related to the drug, the patient's condition. Maybe there are not adequate levels achieved. Maybe the quality of itraconazole has not been good. So all these factors have to also come in. As for the correlation between the in vitro susceptibility versus whether the patient responds or fails, so like we have done in this paper on terbinafine, so most patients who had low MIC, they would respond to terbinafine. But a lot of those with high MICs and harboring isolates with SQLE mutated SQLE genes would also respond when we increase the dose of terbinafine. So there is not a one-to-one correlation. There may be different scenarios. So like I highlighted that with increasing the drug exposure in terms of giving a higher dose, we may be actually offsetting the effect of high in vitro MICs to some extent, but to some extent, of course, not completely. So we do not write off a drug which has shown high in vitro MIC. So terbinafine still remains an important drug for Trichophyton indotineae because it does achieve a good cure rate when we use a higher dose of 250 mg/d.
Thank you. Adelia, over to you.
Okay. There are a couple of questions on the same topic, and maybe again, both your opinions would be appreciated. Do you need to either prophylax the context, the household context? Do you need to look at other people in the family and maybe include pets as well? What is the advice being given, or what do you think we should be doing?
Yes, so it is a common practice to ask if other members of the family are also affected because we do often see infections where two members or even more members out of the family are simultaneously affected, and especially so in smaller children and infants and early life, there would always be a caregiver who also harbors the infection if a very small child comes with an infection. So it's important to ask, and then also with the perspective of relapses because a relapse may also be a reinfection from another infected family member. So that point also has to be kept in mind. So family members, not a screening per se. I mean, it will be very difficult in a clinical setting to call everyone every time and screen the whole family, but you could at least ask on history if anyone else is also affected.
Ali, anything to add to that?
That was very, very good response. I have nothing to say except the fact that I think within the few years, we will see more evidence of sexual transmission of indotineae as well. Another dilemma here is also whether T. indotineae as a pathogen has anything different in the way it survives in the environment. And now we go back to Candida auris versus other candidas. Why this one? Why this particular Trichophyton species behaves differently, and whether there is higher transmission rate, there is more skin shedding. We really don't know, and there is no evidence for that. And also, we don't know the role of fomites in the transmission of indotineae. So I think this also highlights a larger question or area for places like MRC Center to look at dermatophytes as pathogens that have been, in my opinion, neglected among many other fungi for many years, lack of funding and all of those things. They are now a public health issue. We need to think about them outside just as a nail pathogen that causes nail deformity. And I think with that, we can answer these questions and probably put some measures from public health perspective.
Yeah, yeah. And on the topic of the sexual transmitted cases, I mean, there is a question about that in the Q&A as well. Are there any updates on that? Is that something what is emerging? And somebody is referring to a paper in 2024 from Spivak in EID.
Yeah.
Any updates on that?
Very briefly, I just want to say the recent observations about sexual transmission of dermatophytes, it's not unique to Trichophyton indotineae. The paper that was referred in the chat is also a Trichophyton mentagrophytes complex, genotype 7 or 8 as far as I can 7 as far as I can remember, and it was mainly have been described in among MSM population. I think it's an area that we need to think about, and we need to see whether there are more things coming up within next few months or even years. We don't know much. Obviously, sexual transmission of dermatophytes is known, but it was always few case reports within 30, 40 years of medical history. Recently, there is an emergence on that, and I can say in addition to EID, there are 2 more case reports. I think one of them is in JAMA Dermatology, and the other one is in another American dermatology journal. So there are growing, but there are still case reports. Whether this is going to grow, I don't know at this stage.
Yeah, so it's basically a skin to skin contact. So sexual transmission is also very likely.
Absolutely.
So, and it does happen.
Yeah. So
Next one
So
for you, Anu.
yeah, Delia. So Ananta, I have one question for you. You have shown, I mean, terbinafine, itraconazole, I mean, all these drugs, how they're used. But what would you say, what is the most effective treatment recommendation for this infection in resource-limited settings? Like, I mean, you are dealing with resource-limited settings. So what will you say that which one is the most effective treatment considering poor resources?
Yes, so the most effective treatment, of course, remains itraconazole if we go by the cure rates against Trichophyton indotineae. So itraconazole does score above terbinafine standard or higher doses of terbinafine also. So in a resource limited setting, what is also important to consider is what I mentioned towards the end of my talk is how useful is then adding a topical antifungal for applying over extensive skin infections. So that is something which probably could be omitted in favor of a bland emollient, which would reduce the pruritus, the itching for the patient. So that is one thing we could do. Just use a systemic antifungal, systemic itraconazole in the optimum dose and duration, and probably let go of the topical antifungal, because anyways, the patients, when the infection is so extensive, it is very unlikely that they will be compliant with topical treatment, and how much it really adds to an effective systemic antifungal is also doubtful.
Can I also highlight exactly on the back of your comment, the treatment of T. indotineae in pregnancy is another nightmare. Would you like to comment on that?
Right. Yes. So in pregnancy, what we are most comfortable with prescribing is, of course, topical antifungals there.
Yeah.
So there has been a recent paper demonstrating a lot of more than many thousands of pregnancies where terbinafine exposure was not associated with any teratogenicity. So that's reassuring. But then again, the durations we are using now, the doses of terbinafine we are using now are more than what those exposures which were reported in that paper entailed. So we still have to be careful, although terbinafine appears to be safe in pregnancy.
So Adelia, can I ask one question?
Yeah, sure.
My personal. So Ananta, thank you. So Ananta, you mentioned about itraconazole. So my question is that how much burden, how much resistance in itraconazole and Trichophyton indotineae you have encountered in vitro MIC data, and that too correlated in vitro MIC data with the treatment outcome? Do you have any experience with that? Because itraconazole is known to have continuous use will definitely have itraconazole resistance more in coming years.
Yes, so well, in all the recent work, and it has all been collaborative work with you, I don't think there are any significant number of high MIC to itraconazole noted in isolates. And clinically also, itraconazole rarely fails. So they can be a slow response, or there may be a time when you need to increase the dose, but a failure to itraconazole in a clinical setting is very unusual. So when it happens, you have to look at other factors like the bioavailability of the conventional itraconazole formulations is always doubtful sometimes, depending on the quality of the formulation you're using and how the patient is taking it. So at best, also a pellet-based formulation would give about 55% bioavailability. So only that much amount of the drug will be absorbed. So we now have the super bioavailable itraconazole in India. A lot of brands are available now. So with that, we can expect more of the drug to be absorbed. A lot of issues related to the stomach pH required for absorption and the effect of food. So they are all overcome with using super bioavailable itraconazole. So yes, itraconazole failure, if it does happen, these are the factors we have to look at before a high in vitro MIC, at least so far. Yeah.
So another question is also for, you projected this KOH correlation in Trichophyton indotineae. So one of the question is that, is there any difference in KOH findings in T. indotineae directly from the patient sample?
Yes, so it is in an untreated patient who has not taken any antifungals, we rarely find a negative KOH. And the only reason for the negative KOH in that setting was if the sample has not been taken correctly or not been, not given enough time in seeing the smear. So it's rarely negative otherwise. So that's for the diagnostic part. And for follow-up part, yes, we did notice a change, this shift in the change in the hyphal morphology occurring anywhere around 3 weeks of an effective antifungal. So if you're giving an antifungal which is actually not effective for the isolate the patient is infected with, so this change of hyphal morphology, which we observe in KOH, we do in the OPDs, will not happen in that amount of time.
Thank you. Over to you, Adelia.
Reading a very interesting question, and I don't think it's specifically maybe for the dermatophyte, but it's really touching on antifungal resistance, I think, more in the broader scope. And maybe Anu, you can also come into that discussion or comments on that. So what is written in the Q&A is, what is the experience? And thank you, Kabir Sardana, for putting this in front of us. What is the experience outside India of patients who fail supervised itraconazole for 6 to 8 weeks? We have noted an enhanced expression of efflux pumps in a publication. Are there any other causes? And then the question is there a way to block the efflux pumps? So to keep itraconazole kind of active against, in this case, the Trichophyton, but maybe also in other cases. Any comments, any data, any thoughts?
Yeah, so we do have to look for factors, which are contributing to the lower response to itraconazole. So, the doses and the dosing regimes for itraconazole used to be 100 mg for 2 weeks, 200 mg for 1 week, and that would cure tinea skin infections. But now for Trichophyton indotineae, which seems to be susceptible in vitro, we are having to give much longer durations of treatment. So why that is happening, I mean, that does require more research. What factors are contributing to that?
Yeah. Any other comments on that?
Ali?
No, I totally agree. And in our experience also, we do not treat Trichophyton indotineae at least less than 2 months. So, but I have to say, sometimes I ask this question as a patient, do I want to have 2 months of terbinafine? Obviously, the answer is no, but it's not an easy drug to convince people to have as well. So I just want to go back to what exactly Ananta mentioned, and that is sometimes the issue, it's not just in vitro resistant per se, but also there are other biological things about the drug, taking it And obviously the question also referred to observed taking, but I don't know, I'm not aware of this in the UK, that you can have an observation for prescribing itraconazole, but it's a valid question and I don't have the answer.
I mean, these are multiple factors in itraconazole resistance, and we have some very exciting whole genome data, which I'm not going to elaborate in detail because the work is still going on, where we have these Trichophyton indotineae isolates with known high MIC, 16 milligram itraconazole MIC. And when we could compare the genomes of these indotineae isolates, there are several important changes in the, not only in the genes, but more important in the intergenic spaces, right? So maybe there are several other factors in the genome where when itraconazole resistance occurs. So of course, pumps of efflux pumps are important, but as such, we do not know much about Trichophyton indotineae because a lot of data is missing. I mean, we still have very few annotated genomes available, and we do not have RNA-seq analysis or transcriptomics data. So, but yes, the genome definitely shows a lot of changes in addition to the expression, which you copy number variations of these CYP51B gene. So I think in future we'll have more, we can answer this question better than at present.
Yeah, okay. I think that there are a lot of projects which could be done in a research lab on the topic of both Trichophyton indotineae to understand this fungus more, why it behaves as it behaves, as well as the antifungal resistance aspect of it. But what goes broader than probably the Trichophyton indotineae in my mind, because obviously it's a problem in a number of other fungal diseases we see across the globe at the moment. Yeah. Okay, I'm just scrolling through the Q&A, but I think we have touched on most of it. Thanks, Jonathan, for giving us a link to a more recent MMWR update on sexual transmitted Trichophyton infections. There's a comment about mycology nomenclature-wise, what's quite complicated, but I don't think we can solve that problem. We are all struggling sometimes with that, and especially if there's name changing going on. No, I can't see anything else, Anu. Do you have anything else?
Just one question. The person has written that, can we see again Dr. Ananta's slide regarding the conclusion of itraconazole treatment?
Okay.
Should I share?
You can just talk about it, I mean, brief points of the conclusion of itraconazole treatment.
Okay, so
yeah, maybe the person who has asked for that, can you put in the Q&A if there's a specific question you have regarding the summary slide? Okay. And then in the meantime, Ananta, if you can bring up that slide, that would be great.
Yeah, would it be possible at the end to go back to the summary slide regarding the treatment with itraconazole? That's the question.
Yeah, I'll just reach that slide. Just one sec. Okay. Yeah, so this was a summary slide. So highlighting the high efficacy of itraconazole overall, similar cure rates, treatment durations for 100 mg, 200 mg dose, and relapses being seen irrespective of the dose and the treatment duration used. And then the cost effectiveness of the 3 doses in treatment of indotineae skin infections, the higher cost associated with achieving a cure with 200 or 400 mg doses vis-a-vis achieving a cure with 100 mg doses. So, yeah.
Thank you. Thank you.
Yeah, thanks for that. And that reminds me, maybe as a last question then, relapses, I mean, what is the current data? Does that support that the treatment has not been long enough, or that the patient or the person is still exposed to a kind of environmental niche where the Trichophyton indotineae is, and that it's re-exposure, so a new infection basically? But I don't know if there's any data around that, what supports one or the other.
No, I don't think so. In fact, as a clinician also, I mean, I would be really interested to know how much of the organism is present in the patient's environment. So when they come with a relapse, is it some dormant forms existent on the skin which became active again, or was it something left in the environment and that caused a re-exposure or a reinfection? So these are questions we struggle with also all the time. I mean, we advise all patients to separate their laundry, to use towels separately, to wash their laundry in hot water, just assuming that would take care of any dormant forms there. But I mean, it's not really evidence-based.
Yeah. And do we know if the Trichophyton indotineae can resist higher temperatures?
It was known for rubrum that up to beyond 60 is required to clear clothes and other fomites of Trichophyton rubrum. I'm not sure if for indotineae we have similar data. Dr. Ananta, if you could comment on that.
I can just say that, I wanted to pose this question, Adelia, that is this, I mean, we know that global warming and heat and all these factors has brought into forefront about so many fungal infections. So, I mean, Trichophyton indotineae could also be one of them. Is it possible? Because we've done some preliminary studies when we have grown the cultures of T. indotineae at 37, 40, and as compared to them with other species. But T. indotineae grows at 37 and, unlike other dermatophytes, which do not grow outside so well at 37.
Yeah.
So it has more luxurious growth at 37, right? Although it's recommended at 28. So I personally feel that, probably, and India, we have such a hot, humid condition. Africa, where a lot of dermatophytosis. So that really plays an important role, weather, environment. But adaptation, thermal adaptation and all needs to be worked on. But definitely we see a good amount of growth at 37 of T. indotineae.
Yeah. Okay.
And,
okay. Okay, thank you so much. I think we will bring this to a close. I think we had a fantastic discussion after two really wonderful presentations showing us the challenges of Trichophyton indotineae. So thanks again, Ali and Ananta, for your contribution to this MycoClinics. And it was lovely to share with you, Anu, and have your expertise in this topic as well. Thanks to the audience for putting your answers and or your questions in the chat and giving us the opportunity to discuss them. Wish you a really festive end of the month, end of the year, and hope you will join us next year. So bye for now.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.